Good morning, all. Uh, at the outset, I would like to thank Lalit sir for this opportunity. It's an honor to be presenting here. So, I'll be talking about an update on an overview about angiogenesis. I'll try not to indulge too much into the basics of it. So, the basic definition of angiogenesis is formation of new blood vessels from pre-existing ones. It involves migration, growth, and differentiation of endothelial cells. As you see here, it just starts, and this is how the blood vessels actually start growing. So, it's not just pathological; it's even physiological. It occurs throughout the life in both health and disease. So, that's the main thing that we need to understand about angiogenesis. When we talk about angiogenesis, the other thing that comes into mind is vasculogenesis. Vasculogenesis is a normal physiological thing which happens to denote development of blood vessels, especially in the development of primitive heart and major blood vessels. And it starts from at the first and second trimester. So once a new blood vessels start forming, from there angiogenesis takes over. So this is how it happens in 6th week and 18th week. You can see excessive branching angiogenesis, and this is a more stabilized angiogenesis at term pregnancy at the bottom figure. So angiogenesis, again, there are different types. Sprouting angiogenesis was discovered some 200 years back. This is how it sprouts. So when you have an angiogenic stimulus, the hypoxia, there is a breach in the blood vessels, and endothelial cells start growing. So there is another concept called intersusceptive angiogenesis, wherein the blood vessels either split and or they kind of split in between, and then they start growing. So vascular co-option is another phenomenon, especially when we talk about angiogenesis. Most of it is regarding tumors. So this is how the tumor cells grow around the blood vessels, and then they start differentiating. Vascular mimicry, I'll come to detail in another slide. So the basic differences between physiological and pathological angiogenesis. Physiological is because of metabolic demand, shear stress, and hormones. So both physiological and pathological result in increase in blood vessels, wherein you can see a normal branching pattern and normal network pattern length in the physiological thing, whereas you can see a disturbed and abnormal branching as well as abnormal length pattern over here. So therapeutic aspects. When you look at angiogenesis, it's extremely important. Where all do they happen? Physiologically, it's important to have physiological angiogenesis, that is a healthy angiogenesis in wound healing in patients with myocardial ischemia or peripheral artery disease. And in cases like peripheral artery disease, we usually there is something called therapeutic angiogenesis, wherein there is a angiogenesis is induced. So angiogenesis is preferably inhibited. I mean, the preferable choice would be in cases like tumors, cancers, or when it comes to retina, DME, and even AMD, and even in rheumatoid arthritis. So this is a complex interplay of the factors what you see here. So how it starts: VEGF, MMP, and initially the vessel kind of dilates, and then it goes in for proliferation and migration. And you can see the interplay of complex factors, and these are the factors that are anti-angiogenic, which can stop these things at different phases. Over here, you see migration and proliferation and tube formation. So this is a cascade of events. The initial stimulus, and slowly the endothelium starts growing, and you can see the cells growing towards the angiogenic stimulus, the hypoxia or tumor cells. And when you look at normal wound healing and an impaired wound healing, especially in cases like diabetes, burn injury, or ischemia, you see that the angiogenic cyst kind of comes down in impaired wound healing, and the inflammatory infiltrate kind of goes up, and there's a impaired collagen synthesis which results in impaired wound healing. So there is again a risk of relapse and recurrences when you look into these angiogenesis processes, even when you kind of try to balance these things. So angiogenesis usually happens when you have the pro-angiogenic factors which are more than the anti-angiogenic. So that's the reason you get these abnormal blood vessels. And when you kind of treat these things with an anti-angiogenic drug, there is always a chance the balance can shift, and it can come back to again abnormal blood vessels. So this is a balancing act. It's a very fine balancing act. As you can see, the initial stimulators being hypoxia, and this is how it usually progresses. So many factors that are involved, and these are the inhibitors. So it's a fine balance that is maintained in the normal healthy person. So angiogenic switch is wherein you have this angiogenic factors more than anti-angiogenic factors, and that is how the blood vessels start growing. and tumor cells kind of fill. When the switch is off, then the balance is maintained, but the switch is on, then again angiogenesis starts. So this is vasculogenic mimicry, what I was talking about in tumor cells, wherein the tumor cells themselves behave like a vessel-like channels. So these are the key milestones in angiogenesis research and drug discovery. It started way back in 1945, and then 1948, wherein there was a hypothesis of something causing diabetic retinopathy. Angiogenin, 1989, isolation of VEGF. Then it went on to the initial pegaptenib, then again ranibizumab, and then the story follows. So we all know what happens in these conditions, which is important for retina surgeons because of these issues that are strongly involved in DME and PDR as well as in AMD. It's a complex issue, interplay of things. So it's difficult to understand, but if you know the basics of it, it really helps. So the available options are these. The other speakers, following speakers will go into much detail. So these are the current anti-VEGF agents, and these are the retinal diseases molecular signatures. So if you look at neovascular AMD, DME, PDR, and RVO, these are the molecular signatures, and different angiogenic and pro-angiogenic and anti-angiogenic factors play a great role in such conditions. So looking at multiple targets in angiogenesis, so at every step you have different factors that could be targeted to prevent or kind of stop this angiogenesis. So this is how the hypoxia and proteolytic degradation and kind of forms a sprout. So these can be some are explored, some we do have drugs, some are still under research. So these are the potential targets. So if you look at VEGF receptors and tyrosine kinase and FGF, and so these are all the ones which are already kind of the drugs had come out, and these are still yet to go through the approval stages. So these are the treatment options and the drugs in pipeline and different phases. So I'll just, before finishing, I'll just go through quick case examples wherein we had kind of looked at these factors and try to implement in the clinical practice. So it's a incomplete resolution of a CME. It's a persisting CME, and when you look at the array of molecular factors, what we usually do at our place, you can see the VEGF to be on the higher side, and the basic ones like IL-8 and the ICAMs and VCAMs are also on the higher side. Since the inflammatory factors were more, the IVT was given, and you could see the resolution. So but when we took the patient had come in a year later, you can see that the VEGF had come down. So the factors now have changed. The addition molecules were on the higher side. So this is a comparison across first visit and second visit. It's a consecutive thing. You can see the variations in these levels. So when you kind of get to know that what really causes the macular edema, sometimes recurring edema, especially these things can result in better addressing these issues and targeted therapy if possible. Then again, second same case, glaucoma issues, patient uncontrolled diabetes and recurring CME. So you can see the VEGF to be on the higher side initially, and all other factors also on the higher side. So with glaucoma medications, we went ahead and gave an IVTA. So this is how it was. So you can see the VEGF to be completely down initially, but other factors were on the higher side. So third analysis again was done post second injection. So you can see the factors to be VEGF was almost nil, whereas the ICAMs also, the addition molecule also came down over a period of time. So then again, these kind of practical things suggest that there could be future possibilities of wherein we can target these things and get a better treatment outcome. So to conclude, there are different therapies which can be looked into. You can look into pro and antigenic factors and cell therapies and microRNAs and attractive and repulsive vascular guided cues. So it's a complex process. It's highly relevant in routine retinal pathology. So most probably multiple targets, and maybe 10 years from now, maybe we'll be looking at varied agents and newer guidelines to treat these conditions better. Thank you so much. Thanks a lot.
Thanks, Gopi, for covering this in 10 minutes, what books have been written on
Thanks.
vasculogenesis. You see, the gist, whatever he has told us, is that angiogenesis is required for normal, healthy living also. It is when it occurs in a pathology situation like retina, then we get bothered. and the stimulus is hypoxia or inflammation. But unlike healthy angiogenesis, what term he used, these unhealthy vessels or pathological vessels, they are not like God-given vessels. So these vessels are leaky, these vessels are fragile. Leaky means you can have fluid outside, and fragile means they can, rupture. And all attempts are being made to, have control over all these things, and hence the role of anti-VEGFs came up. It all started a couple of decades back. We have had so many anti-VEGFs now available, and there is a very strong tug of war going on between various anti-VEGF agents available. Any question, Malika, you have? Yeah.
Very nice talk, Dr. Santosh.
Thank you.
Since you are doing a lot of research on the angiogenesis and you have a grow lab at your institute, so you nicely showed what are the pro-inflammatory mediators. It could be interleukins, MCPs, ICAM, TNF, alpha, or many other factors. So, is there any way that you can find out that okay, these are more of the pro-inflammatory kind of disease in this patient, and how strong are these anti-VEGFs? Because more basically they are more of VEGF mediated and neutralizing the VEGF receptors.
Good.
So apart from the OCT biomarkers, is there any other way to tell that okay, in these patients the steroids works better or in these patients the anti-VEGF works better?
Now, if you look at OCT biomarkers again, I mean, we did have a small pilot study wherein we looked at the types of edema and what are these factors that were elevated, but it was a small study. So the only thing is, as sir was also saying, it's a complex interplay. So it's really difficult to kind of point out and say that okay, this is a factor that's really causing this. If the patient had already received an anti-VEGF injection, obviously the VEGF load comes down, whereas other factors might be elevated. IL-8 and IL-6 are known to be associated with
I
chronic and
think I think we have a topic for Tirumalesh, what has
right,
been
sir. Yeah, I think
started.
he'll be talking about
Can
those
we
also.
can we road ahead? Can we titrate prognosticate based on
Correct.
whatever research
Yeah.
you people have done regarding targeted therapy or which cytokines, and can we inhibit specifically, and which disease they are elevated? So thanks, Gopi, and
Thank you, sir.
Thank
we
you very
will
much.
move.